Welcome to DentalXP.com. I'm Dr. Maurice Salama, and in today's presentation we're going to be highlighting the treatment of the edentulous posterior mandible. We're going to be showing you a case that was treatment planned from the cone beam image and taken through on materialized Simplant 3D software. And we're planning, as you can see, to place implants in previously extracted and grafted areas of the posterior left, first and second molars and second bicuspid. We're going to take advantage of this cone beam to evaluate the position of the nerve, as well as to evaluate the length and positioning's distribution of the implants involved. In this case, we're going to be utilizing MIS implants, a 10 millimeter by 3.75 in the bicuspid, just clear of the nerve, and then 5 by 8.5 implants in the first and second molar regions. Again, paying attention to the position of the crest. We also intraorally inspect the mucosa to keratinized tissue position, and it's obvious here that we're going to need to position the keratinized gingiva carefully towards the buccal as part of our implant treatment. We want to have at least 2 millimeters of keratinized tissue on both aspects, buccal and lingual, of the future implant restoration. Lingual crestal incisions are utilized to the ramus, and then we do a sulcular approach just distal to the second bicuspid. A microperiosteal elevator is utilized to reflect the flap and expose the underlying osseous anatomy. And here we're utilizing Devimed instrumentation from their periodontal kit, and we're exposing the bone, and you can see the accuracy of what we saw in the cone beam image. A restorative guide is then utilized to initiate the first round drill that enters directly in the position of the future screw access channel or central fossa of the future restorations. This is taken from the cone beam image. This is a duplicate of the surgical guide that was painted with barium sulfate, and you can see those initial drill holes now coordinate with the future position of the screw access and restorations. This is really important to make sure that these initial pilot drills are placed in the right position. The 2 millimeter twist drills are then placed at 10 millimeters in the second bicuspid region, 8.5 millimeters in depth in the first and second molar region. And we recall from the cone beam image that we understood that we were going to have slight facial dehiscences of about 1.5 to 2 millimeters on the distal 2 implants. And we planned bone grafting in those areas as part of our treatment plan. Direction indicators are then inserted, and immediately after the 2 millimeter twist drill, we want to verify the accuracy of our initial drilling. So again, the duplicate of the surgical guide is inserted. This is also going to facilitate immediate temporization. And we initiate and begin enlarging the osteotomy sites for the appropriate dimensions of the implants to be inserted. The 3 millimeter twists are utilized in succession, and every attempt is made to keep parallel the drills as they are inserted. The final drills for the 3.75 millimeter implant is inserted. Again, you can see how we move from one osteotomy to the other, maintaining parallelism in each drilling episode. Copious irrigation is utilized. We try to use cool water, and you can see that these drills turn very nicely. The blue colored final drill for the 5 millimeter posterior molar implants are then inserted, and you can see wider implants in here are handled and managed quite well. We always like to have at least 2 millimeters of bone on the buccolingual aspects before we go to the final drills. If we do not have that dimension, then we would proceed with a smaller diameter implant instead. The final drills are utilized before going on to the conical drills. These conical drills are given free of charge as part of the implant kits that are distributed by MIS. So these are dedicated conical drills that enlarge the top of the osteotomy to allow for insertion of the appropriate diameter implants. So there's a conical drill for the 3.75, and there's also a conical drill for the wider 5.0 millimeter implants. So in the distalmost area, second molar, we're going to insert the 5 millimeter by 8.5 diameter, 8.5 length implant, making sure that we place the implant even with the crest of the bony ridge, exactly as we planned it on the cone beam image, and just above the mandibular nerve. The area of the first molar, also a 5 millimeter by 8.5 length implant is inserted, and you can see that we have excellent bone stability, and we ratchet down these implants to beyond 40 Newton centimeters of initial torque insertion value. In the second bicuspid area, we're going to insert a 3.75 millimeter by 10 millimeter long implant, and we again verify the screw access channels and abutment locations will coincide with the future restorations. Implant carriers are then removed from the tops of the implants, and again, I'm always pleasantly surprised by the significant accuracy in utilizing 3D imaging and cone beam in terms of our planning. You can see the slight dehiscence on the crestal aspect and buccal of the second and first molar implants, and we're going to utilize immediate placement of the final abutments. You can see the flat sides are placed towards the buccal with the internal hex, which has been coordinated to fit towards the facial aspect, so the final abutments can be selected in the process that we've termed one abutment, one time, something my brother and I had talked about and developed years ago. The concept of being able to place abutments so they never have to be removed as part of the future restorative procedures, leaving us with a tight connection and preserves the crestal bone. A suture is going to be initiated on the mesial aspect of the first molar, and then bone graft material, this is mineralized irradiated allograft bone, is going to be utilized. These are cortical and cancellous chips to augment the small dehiscence on the first and second molar implants that have been placed. PRGF and fibrin are utilized as an autologous membrane to stabilize and protect the bone graft, as well as to act as a barrier membrane. This is a resorbable autologous material with growth factors, something I've learned from Dr. Eduardo Anitwa. Plasma-rich in growth factors, and fibrin is something that I've utilized quite routinely in my clinical practice and has been highlighted over and over again on my clinical videos on Dental XP. I'm a big fan of utilizing the interrupted vertical sling mattress sutures whenever I'm going to reposition the keratinized tissue on the buccal aspect. I use this whether I'm going to position the tissue coronally or whether I'm going to position the tissue apically. So I can take that keratinized gingiva that was more towards the lingual, and then utilizing the sling sutures, I can then position the keratinized tissue towards the buccal aspect of the permanent abutments. So we've been able in one procedure to not only place the appropriate implants in their positions accurately, but also to augment the small dehiscences of bone on the buccal aspect of the distal 2 molar implants. Again, sling mattress sutures utilizing a 5/0 vicryl suture is then utilized, and then interrupted sutures as we move distally. We've been able to keep a band of 2 millimeters of keratinized tissue towards the buccal aspect, which to me is an absolute must. If I don't have at least 2 millimeters on each side of the future implant abutments, then my suggestion would either be to do a preliminary soft tissue augmentation procedure prior to implant placement, or it can be done at second stage uncovering of the implant utilizing free gingival graft and a vestibuloplasty type of surgical procedure. One of the biggest dilemmas I see clinically is when people place implants in the posterior mandible without taking care to make certain that they have keratinized gingiva on the facial aspect of their future restorations. This is an area that's usually limited in terms of the amounts of keratinized tissue, and this becomes even more of an issue when these teeth are lost due to extraction. We're then going to irrigate the area as you see here, and we're going to locate the keratinized tissue quite clearly here just below the chamfer or shoulder of the permanent abutments. We're then going to use a replica of the surgical guide that was painted with barium sulfate, and we're going to use that for our temporaries. And you can see we have options here. We can take impressions, that snap-on impression caps can be placed and can be sent to the lab the day of surgery to be more efficient. This doesn't have to be the only opportunity. Other options are available. You can simply place healing caps over these abutments that will assist in keeping the tissue to the buccal. Or if the implants are very stable, as they were here, very good, very high Hounsfield units and good initial torque insertion above 40 Newton centimeters, we simply put acrylic copings that were fabricated chairside on the abutment analogs, and then utilized the restorative guide filled with triad material. And after approximately 3 minutes, we then remove this vacuform matrix and it picks up the acrylic copings. And now we have an immediate, fixed, splinted, temporary restoration. It's always very important that if you're going to cement the case, that you seal the screw access channels. We do this either with silicone material, or we can also use barricade, which is being utilized here. This is a light-cured periodontal dressing, and we simply secure that. It's easy to place and easy to remove. Temporary restoration is then carved chairside and inserted, and then checked to make sure that there is no contacts. And you can see the slight contact on the distal lingual of the first molar. We're going to make sure that we carve that away so there's no contacts in centric or in excursive movements. PRGF material is then syringed around the remaining sutures, and we cement only with antibiotic ointment. No traditional dental cements are utilized. At approximately 2 months, David Garber went ahead, and with a healed tissue now to work with, he went ahead and utilized snap caps over the permanent abutments, which have never been removed from the case. And in order to develop accuracy and to have no distortion with utilizing multiple snap caps, he likes to splint them utilizing a flowable composite resin material. This flowable composite resin simply secures the 3 snap caps so that they will not be able to be moved in the impression, and this maximizes the predictability of the restorative phase. The accuracy of the impression is much better when we splint the copings, as you see here. This can be done in an indirect method, as you see in this case, in this video, or it can be done in an indirect method with the screws coming through the tops of the tray. An improgum or polysiloxane material with high accuracy is then utilized to pick up these snap caps and send off to the lab for the fabrication of the final restoration on accurate soft tissue model. Silicone is then placed. That's the preference for us over barricade for final restorations. And that also allows us to maintain a covered and protected screw access channel. Again, barricade is going to be placed on top of the silicone to seal off that space. Look at the healing on the posterior after only 2 months. Beautiful healing with keratinized tissue on both the buccal and lingual aspects. This was all done in one sitting, immediate placement, immediate temporization, at the same time as bone grafting with PRGF and fibrin. You can see the preoperative PA x-ray, and then in approximately 2 months when the impressions are taken, you can see how nicely the bone has adapted because the abutments have never been removed. The bone levels and tissue levels have been maintained in a healthy form, and the abutments, again, one abutment one time, never being removed, and the accuracy of the final x-rays of the framework of the final splinted 3-unit bridge. I hope that you enjoyed today's video of the planning and surgical and restorative phases of the posterior mandible. And I hope that we will once again see you back at dentalxp.com for more interesting surgical and restorative videos. Thank you very much. This is Dr. Maurice Salama.